بسیار عالی. دوستان عزیزم، چهارشنبه شب دیگه رو در خدمتتون هستیم. من افشین فرغانی هستم و همراه دوست عزیزم دکتر شکرچی و همچنین خانم دکتر بابازاده در خدمتتون هستیم. دوستان سلام. امشب برنامه رو با قطعه‌ای سلام میترا جان، با قطعه‌ای از آلبوم سگاه رسوای دل استاد شجریان شروع کردیم که ادای دینی کرده باشیم به این بزرگ مردی که واقعا دریغ از دست دادنش رو داریم این روزها از فرهنگ و هنر این کشور. بحث جلسه امروز ما همچنان که در جریان هستی در رابطه با نحوه بررسی بیماری‌های قلبی هست. فارغ از این که بخش مدیکال در واقع ما به اپتیموم مدیکال تراپی رسیده باشیم، از اون به بعد آیا کدوم در واقع اپروچ رو در پی بگیریم، بخش نان اینویزیو یا اینویزیو رو بحث داغی بوده، بحث‌های مختلف در گروه هم مطرح شده و امیدوارم که توی این جلسه دوستان بتونن با مشارکت فعالشون به هر حال این بحث رو یه جون تازه‌ای بدن. در این جلسه همونجور که میدونید در خدمت آقای دکتر کیوان کریمی هستیم و من ازشون خواهش میکنم که کیوان عزیز تشریف بیارن داخل اتاق. و دکتر جان سلام عرض شد.
سلام علیکم.
خسته نباشید بعد یه روز کاری سخت به هر حال احتمالاً.
بله خیلی بد نبود، مرسی.
کیوان جان، همچنان که احتمالاً در جریان قرار گرفتیم، به هر حال یه بحث داغی بوده در گروه و خارج از گروه، حتی در میان دوستان جی پی همچنین بحث خیلی به انواع مختلف مطرح شده و امیدوارم که بحث امروز این مقداری کمک کنه که این مقداری روشن‌تر بشه ذهن‌ها در این رابطه. و میدونم که شما کیس ریپورت هایی هم دارید که امیدوارم دوستان تو اون قسمت کیس های مقداری مشارکت فعالی بکنن که بحث پربارتر و بهتر بشه.
منم به همین جهت، منم به همین طور.
خشایار جان، میترا جان، اگر شما صحبتی ندارین ما گوی و میدان رو در خدمت دکتر کریمی عزیز بگذاریم. ضمن اینکه یک معرفی هم از خودتون بفرمایید دکتر کریمی که دوستان با شما بهتر آشنا بشن و بعد در خدمتتون هستیم.
بله مرسی افشین جان و مرسی بچه‌ها.
خیلی ممنونم.
به اصطلاح اجازه رو دادین که من در خدمتتون برسم و توی گروهتون راجع به این موضوعی که همونطور که افشین جان اشاره کردن صحبت بکنم. من اول میخوام این اسکرین رو شیر کنم، مطمئن شم که همه میبینند. خب اسکرین دیده میشه؟ خب همه که رفتن.
بله. این کاملا اوکی.
من کیوان کریمی هستم. من اینترونشنال کاردیولوژیست هستم توی RPA و ماتر هاسپیتالز. من همچنین یک کلاه ریسرچری هم به سرم میذارم. سینیور لکچرر هستم توی یونیورسیتی آف سیدنی و امروز میخوام راجع به همون بحثی که افشین جان اشاره کردن، اینویزیو یا نان اینویزیو منیجمنت آف استیبل کورونری دیزیز صحبت بکنم. تو این کانتکست من راجع به ترایالی که همین بحث رو شروع کرده، اسکیمیا ترایال که اخیراً توی نیو انگلند جنرال مدیسین هم چاپ شده صحبت میکنم و بعد یه خلاصه از اون ارائه میدم در عرض 10-15 دقیقه. بعدش ما 4 تا کیس خواهیم داشت که من امیدوارم که به شکل اینتراکتیو برگزار بکنیم که تو اون کیس ما ببینیم واقعا تو ریل ورلد ببینیم ایمپلیکیشن این فایندینگ های اسکیمیا چی هست و واقعا تا چه حدی میشه اینها رو اپلای کرد و واقعا ببینیم که واقعا درست و غلط به اصطلاح منیجمنت چه خواهد بود. تو اسکیمیا ترایل در درجه اول من راجع به بک‌گراندش صحبت میکنم. اسکیمیک هارت دیزیز میدونی که 2 قسمت داره، ACS یا استیبل کورونری دیزیز. تو استیبل کورونری دیزیز ریلی هدف درمان اینه که ما میزان انجانا رو کم بکنیم و هوپفولی سروایوال مریض رو بهتر بکنیم و initial management stable coronary disease really optimal medical treatment هست. This is universal regardless of اینکه شما بخواید اینویزیو از طریق اینویزیو درمان بکنید نان اینویزیو، اپتیمال مدیکال تراپی که شامل اینتنسیو لایف استایل مودیفیکیشن و تریتمنت کاردیاک ریسک فاکتورز و سیمپتوم ها هست، به هر حال اینا یونیورسال هستن. و سوال اینه که واقعا چه ارزش افزوده‌ای ما با ریواسکولاریزیشن خواهیم داشت، مخصوصا تو کسایی که at least moderate to severe ischemia توی استرس تست دارن. توی اسلاید بعدی اگه بیاد، بله، دو تا ترایال قبلی بوده به اسم کارج اند بری 2D ترایال، دو تا ترایال بزرگی بودن که توی استیبل اسکمیک هارت دیزیز انجام شدن و اینها نشون دادن که دث یا MI با ریواسکولاریزیشن آیده با PCI یا بایپاس کم نمیشه. ولی خب این استادیا لیمیتیشن هایی داشتن. این مریضایی که انرول شدن تو این استادیا بعد از انجیوگرافی انجام شده بود، بنابراین کسایی که انرول میکردن میدونستن که آناتومی چیه. این باعث شد که سلکشن بایاسی وارد شه و هیچ کس مثلا های ریسک آناتومیکال پیشنت رو وارد این استادیا نکرده بود. مثلا کسی که مثلا 80% 90% پروکسیمال LAD داشت واقعا رندومایز نشده بود و بیشتر مریضا واقعا مینیمال تو مادرید اسکیمیا داشتن. بقیه لیمیتیشن‌هاش هم این استادیا این بوده که اینا استنت هایی که اخیراً در مورد سکند جنریشن استنت استفاده نکرده بودن، اینا از what we call physiologic guidance که واقعا ما توی کتلب پرشر وایرایی داریم که میام اندازه میگیریم که چقدر اسکیمیا یه لیژن داره درست میکنه و بر اساس اون درمان میکنیم. این استفاده نشده بود. تکنیک های مدرن جراحی استفاده از اینترنال ممری آرتری که واقعا بهترین کندویت جراحی هست، بایلترایی واقعا استفاده نشده بود و همچنین فارماکوتراپی تو این استادیا واقعا اپتیمال نبود. و گوینگ اینتو اسکیمیا، قبل از که اسکیمیا انجام بشه، دیتاهای خیلی زیادی از very large registry وجود داشت از 50 تا 70 هزار مریض که نشون میداد که بر اساس درجه اسکیمیا توی مایوکاردیوم که توی اینجا مشاهده میکنین، اگر اسکیمیا مایل باشه، یعنی زیر 10% مایوکاردیوم در خطر باشه اسکیمیک باشه، واقعا مدیکال تراپی و ریواسکولاریزیشن یکسان بودن. ولی وقتی که به ترشولد 10% مایوکاردیوم میرسیدین، ریواسکولاریزیشن واقعا سوپریور بود نسبت به مدیکال تراپی توی کم کردن کاردیاک دث. ولی خب این استادیا همشون نان رندومایز بودن. خب توی این کانتست اسکیمیا ترایال برگزار شد که با NIH فاندد بود، $100 میلیون خرجش شده، 120 سنتر توی دنیا تو شرکت کردن و اینا اومدن مریضایی که استیبل کورونری آرتری دیزیز داشتن رو با 5 مودالیتی 5 تا استرس تست اومدن استراتیفای کردن به کسایی که at least moderate اسکیمیا داشته باشن و این کورلب اینو خونده بود، نه فقط سایت ها. و کسایی که اکسکلود شده، اینا خیلی مهمه، کسایی که انجاینای زیادی داشتن، اینا کسایی که تو این ترایل بودن، کسایی بودن که مایلد انجاینا داشتن یا اصلا انجاینا نداشتن، یا که مثلا ماهی یه بار یا هفته یه بار مایلد دیگریز اف انجاینا. اینا کسایی که ACS داشتن و کسایی که PCI یا کبد شده بودن در عرض یک سال اخیر، کسایی که تو هارت فیلیر کلاس 3 کلاس 4 بودن، یا کسایی که LV ejection fraction distance 35% بودن رو واقعا اکسکلود کردن و همچنین کسایی که CKD داشتن که اونا انرول شدن تو اسکیمیا CKD. بعد همه این مریضا اومدن یه بلایند CT کورونری انجیوگرام شدن. چرا بلایندد؟ این تصویرها فرستاده شده بود به کور لابراتوری، اونجا میخوندن که CT چی هست، برای اینکه همون سلکشن بایاسی که گفتم رو این اوایل بکنن که کسایی که های ریسک هستن هم تو ترایل بمونن. خب کسایی که توی CTCA left main disease داشتند و کسایی که اصلا دیزیزشون نان سیگنیفیکانت بود رو اینا اومدن اکسکلود کردن بر اساس CTCA. خب بعد اومدن اینا رو رندومایز کردن به 2 گروه. یکیش اینویزیو استراتژی هست versus conservative استراتژی. دقت بکنید که تو اینویزیو استراتژی اولین قدم اپتیمال مدیکال تراپی هست. بنابراین اینویزیو استراتژی اینجا ما اپتیمال مدیکال تراپی رو versus ریواسکولاریزیشن مقایسه داریم نمی‌کنیم. یعنی کسایی که توی اینویزیو استراتژی بودن هم اپتیمال مدیکال تراپی دریافت کردن. بعد کاریکاتورایزیشن شدن و ریواسکولاریزیشن شدن، حالا یا PCI یا کبج بر اساس فیزیبیلیتی، آناتومی اتسترا. کسایی که توی کنسرواتیو استراتژی گروپ بودن فقط مدیکال تراپی دریافت کردن و اینها انجیوگرافی هم شدن تو کسایی که اپتیموم مدیکال تراپی فیل کرد، یه ACS پیدا کردن، استمی. یه عده‌شون اونایی که فیل کرده بودن اجازه داشتن که به اصطلاح کراس اوور کنن و انجیوگرافی داشته باشن و میدیم فالوآپ هم 3.2 years بود. خب وقتی شما به استرس تستا نگاه میکنین، حدود 25%شون فقط تردمیل تست انجام دادن، ECG تست. ولی این ECG تستا واقعا early پوزیتیو بودن، یعنی کسایی بودن که زیر 7 متر more than 1.5 میلیمتر ST depression داشتن تو multiple leads و reduced exostolerance. اینا 25% بودن و بقیهشون استرس ایمیجینگ گرفتن که حالا یا پت بوده یا سپک بوده یا کاردیاک یا MRI. وقتی نگاه بکنین درجه زیادی به اصطلاح اسکیمیا وجود داشت، بیش از نیمی از مریضا سیویر ایندیوسیبل اسکیمیا داشتن، یک سومشون مودریت داشتن و 12% مال یا نان. و وقتی شما به درجه کورونری آرتری دیزیز نگاه بکنید روی CTCA میبینید که واقعا به مقدار زیادی کورونری آرتری دیزیز وجود داشت. one vessel disease, two vessel disease, three vessel disease و بیش از 3/4 واقعا مالتی وسل دیزیز داشتن. 90% LAD دیزیز داشتن و 50%شون پروکسیمال LAD اینوالو بوده. بنابراین اینا واقعا ریل دیزیز و ریل بردن اف اتروسکلروزیس داشتن تو این ترایال که این در واقع برخلاف اون دو تا ترایالی که قبلا نشون دادم برای 2D که واقعا مریضایی که در حد مالد اتروسکلروزیس داشتن رو واقعا ریکروت کردن. شما وقتی به کاردیوکاتالایزیشن نگاه می‌کنید تقریبا همه کسایی که اینوازیو آرم بودن کاتترایز شدن، ولی از اینا 80%شون ریواسکولارایز شدن که 3% که به اصطلاح 3/4شون PCI گرفتن، 1/4شون کبج. وقتی شما به کانسرواتیو آرم نگاه می‌کنین التیمتلی 28% اینا هم آنژیوگرام شدن به خاطر دلایلی که من خواهم گفت و 23%شون هم ریواسکولارایز شدن. به چه دلیلی این کانسرواتیوها انجیوگرام پیدا شدن؟ واقعا از 2/3 کسایی که انجیوگرام شدن دلیل واقعی براش وجود داشت، یعنی یه ACS داشتن، آنستیبل انجینا داشتن و حدود 8% به اصطلاح نان ادهرنس یا پروتکل وایلیشن اتفاق افتاد. و کسایی که ریواسکولار شدن بودن 2/3شون واقعا ریل ایونت داشتن. بنابراین چایلیستا کار خیلی خوب کار کردن، میزان نان ادهرنس رو به پروتکل خیلی کم کردن که این سیگنال بین دو تا آرم دایلوت نشه و واقعا نتایج واقعی بگیریم. خب این اسلاید پرایمری آوتکام هست. It was a composite primary outcome: cardiovascular death, MI, hospitalization for unstable angina, heart failure, resuscitated cardiac arrest. وقتی نگاه بکنید توی median of 3.2 years هیچ اختلاف بین دو تا گروه وجود نداشت. نهایتاً هازارد ریشیو و پی ولیو نگاتیو بود. بنابراین این یه ترایال نگاتیو هست. ولی وقتی شما دقیق تر بشین میبینید که در قسمت اول استادی اینوازیو آرم به نظر میرسید که هازارد داشت، یعنی ایونت ها توی اینوازیو آرم بیشتر از نان اینوازیو بوده و این به خاطر پری پروسیجرال MI بوده که اتفاق میافتاد با انجیوگرام و PCI. بعد حدود around 2 years این کرو اومدن کراس اوور کردن و وقت هرچی که دیرتر میشد به نظر میرسید که اینوازیو آرم میزان ایونت ها کمتره و این وقتی به این اشاره خواهم کرد این به خاطر این بوده که میزان اسپونتینیوس MI و لیت MI کمتر بوده توی اینوازیو آرم. ولی اوورال که بهش نگاه بکنین دو تا آرم با هم هیچ فرقی نداشتن بین اینوازیو و نان اینوازیو. بعد شما وقتی به نگاه بکنید به پری اسپسیفاید ایمپورتنت ساب گروپس هیچ فرقی نمیکنه که مریض دیابت داشته باشه نداشته باشه، چقدر فریکانسی انجینا داشته باشه، سیویریتی کورونری آرتری دیزیز 1 وسل 2 وسل 3 وسل باشه، پروکسیمال LAD دیزیز باشه، دیگری ها بیس آن اسکیمیا مودریت باشه، سیویر باشه، هیچ فرقی بین افکتی که شما از اینوازیو استراتژی و نان اینوازیو استراتژی میگرفتین وجود نداشت. وقتی شما به میجر سکندری آوتکام نگاه میکردین که کاردیوواسکولار دث یا MI بوده که واقعا این دوتا میجر ایونت ها بودن که they drove all the events in the trial, most of the events. میبینید که کروا کاملا شبیه اون کروایی که شما توی کامپوزیت پرایمری اندپوینت دیدین و به همون شکل early hazard وجود داره با به اصطلاح invasive approach and late benefit. But overall the adjusted hazard ratio is not different between the two groups for the endpoints of cardiovascular death or MI. مهمترین به اصطلاح endpoint که all cause death has was absolutely the same. The curves are in fact superimposable. They are not different between the two groups. این یه نکته دوم اینه که واقعا از نظر حداقل ما کاردیولوژیستا این مریضا واقعا استیبل coronary disease بودن، برای اینکه واقعا میزان mortality rate per year 1.5% بوده که خیلی بالا نیست. برای اینا واقعا استیبل coronary disease بودن، ولی فرقی نمیکنه که شما invasive درمانشون میکنید یا non invasive. Mortality rate all cause death was completely the same between the two groups. myocardial infarction was به نظر من خیلی جالب بود تو این ترایل. وقتی شما به procedural MI که نگاه میکنید، procedural MI هست که در اثر پروسیجری که شما انجام میدین obviously اتفاق میفته در اثر انجیوگرافی یا PCI. تو invasive arm هزارد وجود داشت، اوایل بیشترین چانس این بیشتر بود compared to conservative، ولی وقتی که شما به spontaneous MI which is non-procedural MI یا late MI نگاه بکنید میبینید که واقعا یک clear difference between the two وجود داشت که این خیلی جالب هست که به نظر من برای اولین بار به شکل خیلی واضحی clearly این ترایل نشون داد که revascularization که خیلی جالبه که اینجا 3/4 PCI بوده، 1/4 بایپاس MI رو کم کرده. تنها ترایل دیگه که با این مقایسه میشه سرجیکال آرم برای 2D بود که اون نشون داد که بایپاس گرافت هم اسپونتینیوس MI رو کم میکنه. فلیپ ساید هارد اندپوینت که به شما نشون دادم واقعا کوالیتی آف لایف هست. اینجا اومدم با سیاتل انجاینا سکور انجاینا کوئسشنر ساماری سکور اومدن اندازه گرفتن که ببینن واقعا انجاینا چه تاثیر داره تریتمنت ها، و اینجا واقعا اینویزیو تراپی سوپریور بود، کم کرد میزان انجاینا رو و این تاثیر هم واقعا ثابت بود، دیوریبل بود از 3 months 12 months 36 months. و این واقعا compared to برای 2D trial که به شما نشون دادم این فرق میکنه. اونجا انجاینا با ریواسکولاریزیشن برای 2 سال بهتر شد، بعد واقعا اثرش از بین رفت. اینجا به نظر میاد که دیوریبل هست و این احتمالاً به خاطری که ما اینجا از second generation drug routing center استفاده میکنیم. وقتی شما دقیق بشین و نگاه بکنید که چه میزان انجاینا از بین رفت بر اساس میزان انجاینا که مریض دو بیسلاین داشت، میبینید که مثلا فرض کن مریضی که مریضی که ویکلی انجاینا داشت بعد 3 ماه 45%شون انجاینا فری بودن توی اینویزیو آرم، و از این conservative arm 15%شون انجاینا فری بودن. With a nominal needed to treat of only 3 to make one patient completely angina free. ولی اگه مریض هیچ انجاینایی توی بیسلاین نداشت، هیچ فرقی تو میزان انجاینا بعد 3 ماه با هیچ کدوم از این با اینویزیو اپروچ یا کانسرواتیو اپروچ وجود نداشت. برای مریضایی که انجاینا ندارند، نه از نظر هارد اند پوینت بنفیتی میگیرن from invasive approach و نه از نظر انجاینا. و این افکت هم دوباره دوریبل بود به همین شکل تو 12 months and 36 months. خب من اینجا بحث راجع به اسکیمی ترایل رو تموم میکنم. هیچ کانکلوژن یا تیک هوم مسیج اینجا نمیدم. میخوام بلافاصله وارد کیس ها بشم. کیس ها رو از اینجا به بعد به انگلیسی میگم برای که یکم راحت تر خواهد بود و واقعا دوست دارم که اینتراکتیو تا جایی که میشه با این کیس ها رو بررسی بکنم. و این کیس ها یکی بعد از دیگه به نظر من کم جالب تر میشه progressively. خب کیس 1. Case number 1. 51-year-old woman who for the last 3 months has been experiencing daily episodes of non-radiating left-sided chest pain and tingling that usually last 30 to 60 seconds at the time, but sometimes it can happen they last for 5 minutes or sometimes 5 seconds. The symptoms are usually exertional, but sometimes occur after eating or at rest. She has no associated symptoms like dyspnea, and these symptoms have been stable for the last 3 months. The cardiac risk factors include current smoking. She smokes 2 packs per day for the past 25 years. There's a positive family history. Father died of heart attack age 60. She's on absolutely no medications, no antiplatelets, no statin. And on physical examination, blood pressure is 128/82, heart rate is 70, LDL is 1.7 millimole per liter. Otherwise, bloods and ECG are unremarkable. So the question here is, how do you manage this patient? And how do you further evaluate this patient? Would you reassure this patient that this pain is not non-ischemic? Would you start anti-anginal, say this is angina, don't do any other testing? Would you perform a treadmill stress test or some form of quantitative ischemia testing? Would you perform CT coronary angiogram, or just say you've got a couple of risk factors, you've got angina, I'm gonna do a coronary angiography. So I'm gonna open up the chat here to see if there's any suggestions by you guys. Okay, 3, 5. So a couple of you guys have suggested treadmill test. One person said CTCA, treadmill test, and SPECT imaging. اوکی خب چیزی که برام جالبه که در درجه اول شما خب اگه یادتون باشه من به شما گفتم که خیلی مهم هستش که ما ریسک فاکتورهای مریض رو کنترل بکنیم. بنابراین اپتیمال مدیکال تراپی از همینجا شروع میشه، smoking cessation, adding statin, etc. But in terms of how we're going to approach and investigate these patients, I think most of you guys suggested either a treadmill stress test or imaging, sort of, stress echo, etc. But if you go with the result of the ischemia trial, the doctor has read that he's the cardiologist and decided to do a CT coronary angiogram. And I'll show you the CT coronary angiogram here. So the CT coronary angiogram was non-obstructive. Okay. What would you do now for this patient? What's your recommendation for this patient who has non-obstructive coronary artery disease? Afshin is suggesting optimal medical therapy. All right, medical therapy, optimal medical therapy, okay. I think we're all agreeable here. The question really is, I think one question that remains in this patient is that, is this pain really cardiac in origin? We haven't really established that, because with non-obstructive coronary disease, obviously this is unlikely to cause angina. But remember, she's a 51-year-old woman who's a smoker, and these patients are really prone to get microvascular dysfunction. So microvascular spasm, endothelial dysfunction. So there is a condition called INOCA, which means ischemia with non-obstructive coronary artery disease, which really fits the sort of profile of this patient. Obviously, we haven't shown any ischemia because we haven't done ischemia testing. So if you're strict, then you now go on this stress echo to prove that the patient has got ischemia. But regardless, I think it's very likely that this patient has got INOCA, which is in ischemia with non-obstructive coronary artery disease. So it's absolutely important that the patient goes on a statin, you drive the LDL cholesterol down, stop smoking, and perhaps also there could be a discussion here whether the patient needs to be on aspirin. I believe so, but that's another discussion for another time. And the choice of whether to start or an anti-angina like a beta blocker, it really depends whether you actually prove that the patient has got ischemia. But this is the bare minimum that we should do for this patient. Okay, the case 2 is a 66-year-old woman who for the past 3 months has been having episodes of non-radiating substernal chest pain, chest pressure that occur only when walking upstairs or running and are relieved within 20 seconds with rest. These episodes happen once or twice per week. There is no associated symptoms like dyspnea. Her cardiac risk factors include hypertension, hyperlipidemia, and past smoking. Her other relevant medication include aspirin, perindopril, amlodipine, and atrovastin with the doses that you can see. On clinical examination, blood pressure is 134/82, heart rate is 80, LDL is 1.9. There's minor non-specific STT wave changes. Otherwise, the rest of his examination is unremarkable. So what would you do with this patient? You say that this is typical angina. I'm going to start anti-angina medication. I'm going to do a stress test. or quantitative stress test, CTCA, or go ahead with the based on the risk factors and perform a coronary angiography. Again, I would like your view here. So I've got coronary angiogram from Dr. Khashayar. Afshin thinks that we should do a quantitative ischemia testing. Eli thinks that we should do coronary angiogram. Fereshte thinks CTCA, and Sarah thinks that we should do CTCA. And also another answer, stress echocardiography as well. Okay, again, so when you look at the profile of this patient, obviously these episodes are very typical with really high risk probability for angina, or ischemic heart disease. And if you really want to follow the protocol that was in ischemia, perhaps the first test should be CTCA. You could argue that in ischemia, they first performed the ischemia testing so that the patient, was eligible to be in the trial. That's correct. But you really here, that there is multiple risk factors, high pretest probability. You want to make sure the patient doesn't have left main disease. So you go ahead and perform CTCA. So CTCA was performed, and there was only mild disease in the left coronary artery, and this is the right coronary artery. And I can read this for you. There is expansive severe mid-RCA obstruction with calcific plaque elsewhere. So now you have a patient with single vessel disease with these cardiac risk factors who has had stable angina for the past once or twice per week for the past 3 months. Now, what do you recommend to this patient? Would you recommend that we do PCI? Would you recommend that we put the patient on medical therapy? What's your recommendation? So Afshin thinks you should do angioplasty. Yeah. Any other takers? Angioplasty, PCI, stent. Okay. It looks like, all right. Okay. It looks like we didn't talk about ischemia trial here. Well, I mean, the reality is that there is no, after ischemia trial, there's no right or wrong answer. It can be PCI, revascularization, or medical therapy. Because we saw that stenting this is not going to prevent death or MI, or the composite of death, MI, all the other sort of issues. So we actually have an informed discussion with this patient. We say that if you stent this, we are not going to prevent you from dropping dead. We're not going to, very likely, we're not going to prevent you from getting MI, although I'll have a discussion about that. It really depends on the patient's goal. So you can give the patient the options. Obviously, you optimize the medical therapy. I think the cholesterol levels are not within the range still. So you add, you increase the dose of statin. Heart rate is 80 beats per minute, so you can actually add a beta blocker here for anti-anginal effects. And then you can then reevaluate within a few months to see if the patient is stable on dose, the angina is better, good, you continue. And if it fails, they can do PCI. But the reality is that if the patient says, look, I don't want any of this. I'm a very active person. I run around. I do a lot of things. I don't want angina. Then you go ahead and do PCI. So really, in the post-ischemia era, we've got time. We don't have to rush the patients to the cath lab. That's the number one outcome of the ischemia trial. We used to rush this patient. You have to go tomorrow. We should put a stent in. But the reality is that we can wait, we can optimize the medical therapy. And then, but at any time point, if the patient says, look, I don't want the angina, I don't want to take 2-3 anti-angina medication, I want to get back to my exercise, then you go ahead and put a stent in. Okay, case number 3. A 74-year-old man with a previous MI on the bottom of his heart 10 years ago. He had an angiogram at that time and was told that he had 2 blocked arteries, but that his heart overall was working well. Angioplasty was recommended, but he refused. He's very physically active. For the past 10 years, he has had mild arm pain when working vigorously in his backyard, pushing a lawnmower or hammering. These symptoms usually resolve within 15 seconds with rest. If they last longer, he takes sublingual GTM, which helps. For the last year, though, he believes the symptoms have been occurring somewhat more frequently and are more easily provoked, but do not occur with non-rigorous activities such as walking. He has now moved interstate to Sydney from Queensland, and his new GP has recommended cardiology evaluation. His cardiac risk factors include hypertension, hyperlipidemia, and past smoking. He's on aspirin, ramipril, atenolol, amlodipine, and atorvastatin, and GTN-PRN. On examination, his blood pressure is 130/78, heart rate is 66, LDL is 3.2. He's got a small inferior Q waves, but nonetheless, they are pathological Q waves, otherwise non-contributory. Okay, at this point, what would you recommend to this guy who's had a previous MI, obviously very high risk? Would you perform a treadmill stress test? Would you do a stress echo or present system EV? Would you perform CT, or you just say you are very high risk, I'm going to do a coronary angiogram on you? Okay. You're having a treadmill, you're having CTCA, another CTCA, you're having angiogram, CTCA, and CTCA. Okay, an angiogram, all right. So no one is doing a stress test anymore, that's good. Well, I mean, I'm not gonna say that's good, we'll discuss that. But very important, Eli said that we should control the cholesterol is extremely important. The cholesterol is extremely high in these patients, 3.2 in such a high risk patient at maximum Lipitor, so we have to really add ezetimibe. And I think it will be hard here in Australia to have access to PCSK9, but that's some patient that needs cutting his cholesterol down to 50%. So PCSK9 would be indicated, although it's not covered by our PBS yet. Well, okay, so we do that. Obviously, here the question is this. The patient had an angiogram 10 years ago, so his cardiologist was a good cardiologist, decided to contact the cardiologist in Queensland and actually get the old pictures. And these are the angiogram from 2010. So he had an occluded OM2 branch of CERC. His RCA was normal, his LVEF was 65% with median inferior wall hypokinesis. And this was his LAD 10 years ago. That's LAD 10 years ago plus left main. Now knowing this, what would you guys recommend? Okay, angiogram. Angio. Okay, interesting. There is angio. Okay, there is universal agreement here as to performing angiogram. Yeah, everyone thinks that we should do an angiogram. Well, yes, I think I can tell you what the actual cardiologist did here. The cardiologist want to do a CTCA, which I think is reasonable to rule out left main disease. The patient angina is slightly worse, but not a lot. So there was some room to increase the atenolol as well. And the patient really didn't want to have CTCA. So they decided as an initial approach to treat the patient medically, which again, based on what you see in the ischemia trial, is not unreasonable. I personally would have performed CTCA if the patient agreed. If the patient having a left main disease, then you could treat them with medical therapy for a while. And again, the discussion would be that if the angina gets more severe despite best medical therapy, then you go ahead and do angiogram. Again, the message is that there is no rush if there's a stable disease and there is no left main disease. The only thing I would have with regards to this patient is that the left main was normal 10 years ago, but you don't know if left main is normal now after 10 years. So that's the only caveat there. Case number 4, 50-year-old man without previous angina or no CAD who 6 months ago developed new-onset substernal chest pain that radiates to his left arm when he climbs the stairs, sometimes with dyspnea that resolves within 30 seconds when he rests. He hasn't sought medical attention, he hasn't told anyone, and his chest pain has been happening 2 to 3 times per week, but has been stable over the past 6 months. Wife, found out about this pain and really made him confess to his GP about the pain and urged him to be reviewed. So patient's father had a stroke, unfortunately, during an angiogram. So he doesn't really want to have an angiogram. All right. So his cardiac risk factors are long-standing diabetes, hypertension, and paroxysmal atrial fibrillation. He's on insulin, pregnenolone, indapamide, apixaban. On examination, his blood pressure is 142/88, heart rate is 66, LDL is 3.5, and HbA1c is 7.8%, otherwise non-contributory. Okay, what would you do with this patient? Which one of these options? I already have a CTCA. So 2 CTCA so far, angiogram, CTCA. Yeah, high lipid treatment, that's absolutely right, optimal medical therapy. And okay, so absolutely correct in terms of optimizing these patients' BSL, cholesterol, and blood pressure. None of them are controlled, so you're gonna increase the pregnenolone dose, you're gonna basically, the patient is not on statin. This patient is not a statin, so that's very interesting. So you start a statin, it will need ezetimibe. You have to really push these patients' LDL cholesterol really low, 1.6 or less. And also HbA1c is not optimally controlled. So all these answers are correct. So do not forget about optimal medical therapy. But then you did all that. So the choice here, I think most of you guys either said CTCA or angiography. Some people suggested angiography. I think CTCA, if you want to go with the ischemia trial, I think it's the best, the right answer. I'm going to show you 3 options, 3 CTCAs, and we're going to discuss what kind of discussion we're going to have in each one of the CTCAs. So it's number 1, left main is not involved. There's mild disease in LAD, mild disease in CIRC, and there's only severe stenosis in RCA. So what would you do with this patient? Single vessel disease, diabetic patient with angina. Okay, at this point, who suggests revascularization? Who suggests medical therapy? Medical therapy, angioplasty, medical therapy. Okay, angioplasty. So there's a split there. It's single vessel disease. The patient has angina, has got diabetes. There is no right or wrong answer. If the patient wants a relief of angina, you can go ahead and do angioplasty. You can also try anti-anginal therapy and optimal medical therapy, and if it fails, then you can go ahead and do an angioplasty. So it's single vessel disease. The next is this CTCA. So there is disease in proximal LAD, severe calcified, and there's a lot of calcium in CIRC and RCA that you can't really assess how severely stenosed these vessels are. So it's potentially 1 vessel, 2 vessel, or triple vessel disease without involvement of the left main. So what would you do with this in this patient with diabetes? Cabbage, okay. Bypass. Cabbage. So most people think cabbage, and I think that's reasonable because triple vessel disease, there's no left main. Again, if you want to go with the ischemia trial, you can, in principle, put this patient on medical therapy. But the reality is that in ischemia trial, we don't even know how many patients with diabetes and triple vessel disease existed for us to really get anything meaningful out of it. So I think if there's triple vessel disease with diabetes, I would err more on the side of revascularization with bypass. And this is the last CTCA, mid RCA lesion, severe, and the patient has 50% left main disease, occluded left CIRC, occluded OM1 and OM2, and calcified lesion in the middle AD that we can't really assess in terms of severity. What do the people think about this one? All right, I need to look at the chat again. All right, so here, cabbage. Okay, so I think this is way more straightforward compared to the last patient because there is left main disease and this patient would have been out of ischemia trial. Okay, so I think we've got around perhaps, because we started 5 minutes, perhaps 5 or 10 minutes. I'm gonna go through some concluding remarks with regards to ischemia, and then we can potentially have 5 minutes for further questions if possible. So as I said, this, in interpreting ischemia, the reduction in non-procedural MI was actually very interesting. So there was a reduction in spontaneous MI or revascularization. And interestingly, this was done in 3/4 of patients with PCI than CABG. So we actually discussed this in this paper in New England Journal of Medicine in response to the authors of ischemia. And we believe that this finding that revascularization ischemia has reduced spontaneous MI challenges the so-called non-obstructive plaque paradigm. So what is a non-obstructive plaque paradigm? It mentions, has been around for the past 20 years, it mentions that severe obstructions like this lesion here in mid-RCA are usually, they don't have a lot of lipid in them, they're usually fibrosed and calcified. Obviously, they're limiting the flow, but because they don't have a lot of lipid or thin caps, they rarely rupture and cause MI. Whereas the non-obstructive plaques that are all around this artery here that you can't see properly on angiography, but you will see that in intravascular imaging, they are more vulnerable because they cause minor obstruction with the eccentric plaques, they've got lipid pool, and the caps are thin. So these thin caps can rupture and cause MI. So MI really is arising from these lesions rather than this one. So if you put a stent here, you're not going to prevent these guys from rupturing. Whereas if you put a bypass here, you're bypassing all these segments. So no matter what rupture you get here, you got the downstream would be prevented. But given the fact that here relieving this obstruction reduced the PCI, I think as we discussed in this piece in New England Journal, it actually challenges this paradigm. And I think these plaques are also prone to rupture and obstruction. And when you put a stent in, you're actually changing the biomechanical forces here and also sealing the plaque from the intracoronary milieu that's then repaired, and you prevent MI. So that's, I think, is a very interesting finding of ischemia. The other aspect of ischemia that was interesting, and I think this might have some implication. If you look at the end of 4 years, these two curves have really separated in favor of invasive approach, and mostly due to MI. The investigations have got money from NIH, so they're going to continue monitoring this patient for the next 3 or 4 years. And if these curves continue to diverge and the p-value becomes positive, p-value becomes significant, then probably in 3 years, we're going to have a different conversation. We're going to say that, look, you have to revascularize because you're preventing MI. So watch this space for the next 3 years. The other aspect of ischemia was that when they looked at the events rates versus the severity of ischemia at baseline, there was no correlation whatsoever with that. So now people are questioning the value of ischemia testing, such as stress testing. And the question is CTCA really the most appropriate screening test? You can look at the left main, you can look at non-obstructive disease. And there was also an association, significant association between anatomic severity of disease and all the outcomes. So CT gives you that. So we actually discussed this in an opinion piece in Current Opinions in Cardiology. I wrote that this Greg Stone, who is one of the main principal investigators of the ischemia trial. He's on that, the ischemia trial paper on the New England Journal of Medicine as well. And we argue that CT FFR can be the gatekeeper for angiography. What is CT FFR? So FFR is fractional flow reserve. We do this invasively in the cath lab by putting a wire, pressure wire, across the lesion. We kind of measure the pressure downstream of the lesion and upstream of it, and we can calculate what's the flow. And if this ratio of FFR is 0.8 or less, it means that that lesion is ischemia producing, flow limiting, and we go ahead and stent them. So by using really sophisticated computational fluid dynamics that requires solving data sets that are as complicated as a jet flying, we can really measure the FFR of every single lesion that you see on CT. And this is already happening. It's already online. It's not just a research tool. It's already online in the US, and eventually will come to Australia as well. So when you order a CT, you get a bunch of lesions, you get a bunch of numbers here. You have a medial AD lesion with 56% stenosis with an FFR of 0.65. So this is significant. These two are not. So we already know before we went to cath lab that there's a medial AD lesion that we have to be dealing with. So perhaps this could be going forward the gatekeeper rather than all the other stress tests that we're doing. So in conclusion, ischemia has really added tremendous amount to our knowledge base upon which we need to make our decision. I think the most important aspect of that is that you don't have to rush patients to cath lab. You can really take your time in stable patients and optimize their medical therapy. Although the findings seem straightforward in the trial application, as you saw, real life patients are really not straightforward. The issue here is that what test to use to diagnose versus how to guide therapy. And there was a bit of a divergence in the answers that you guys were giving as well with this regard. And of course, ischemia is only one trial. It's a major trial. It's probably not going to be repeated, but it does not negate the last 40 years of knowledge about the importance of the number of disease vessels, left ventricular ejection fraction, diabetes, etc. Remember, ischemia excluded patients with ACS. So these results do not apply to ACS patients. They do not apply to heart failure. They do not apply to patients with low ejection fraction and left main disease and patients with substantial angina. So patients having a daily angina, you can't sit on it. You have to offer them revascularization. And also, as I say, ischemia suggests that we probably perhaps don't need to do routine stress testing. Perhaps CTCA would be the best approach, plus or minus FFR CT that I told you. But there are a large number of cardiologists that argue that there's great value to understanding patients' exercise capacity, hemodynamic response, to quantitatively assess the ischemia in terms of both diagnosis and therapeutic prognostication. So we still don't have one size fits all yet. Optimal medical therapy, extremely important. Do not forget, these are not mutually exclusive. Both invasive and non-invasive approach should have optimal medical therapy, and that includes bringing the blood pressure down, ceasing smoking, LDL cholesterol to the target. And I can tell you that in ischemia trial, achieving all four of these was achieved in 20% at baseline, and they can only increase that to 40% of patients, despite giving them free drugs and following it up closely. So it's very important. It shows it's difficult, but it's very important to sort of persevere and achieve that goal. And I'll last leave you with these two slides from Antwan and Bromwald, who wrote the actual editorial for ischemia that accompanied the actual paper in NEJM. They found support for both an initial invasive and an initial conservative approach. They found support for an initial conservative approach was saying that provided that there is a strict adherence to guideline-directed medical therapy, patients with stable coronary disease who fit the profile of those in ischemia, i.e. having mild ischemia or no ischemia, who do not have unacceptable angina, can be treated with an initial conservative strategy. But they also found support for an initial invasive approach, saying, however, an invasive strategy which more effectively relieves angina, we know that clearly, especially in patients who have got more frequent episodes, is a reasonable approach at any point in time. I think that's an important clause here, because we used to think that you should put the patient on one or two anti-anginals, then if you failed that appropriate criteria told you that, then you can go ahead and do revascularization. But with the ischemia trial, we can have that conversation saying, look, we can go ahead and put a stent in, we're gonna make you feel better. We're probably not gonna prevent MI or death, but if you really don't wanna take medications or have angina, we can go ahead and do it now. So you can have that conversation really at any point in time. And with that, I leave you, and thank you very much for your attention. And I believe we might have a few minutes for questions. Okay, Afshin, can you reflect on the importance and efficacy of calcium scoring and when it's appropriate? Okay, I mean, that's another discussion for another session. I think calcium scoring is very important in terms of risk stratification. It adds value to traditional risk score, whether you go with with score system or Framingham scores, risk scoring. I use that quite a bit. I think it's gives you information with regards to presence of any plaques in patient, in which case you really intensify your treatment and set some goals for the patients. So if the patient has a few cardiac risk factors, in particular diabetes or family history, I have a low threshold for using a calcium score, but that wasn't obviously the topic of this, and I think there is one session in this that one of the guys can perhaps talk about it. How much cardiovascular risk factor calculator is worth? I think it's very, very useful in terms of risk stratification. I personally use the SCORE, which is the European guideline. I find it much more intuitive compared to ASCVD from Framingham, but obviously the cardiac risk factor combined with calcium score, it is multiple layers of risk score. Always, majority of time you can add the calcium score, and that really can guide how intensely you go. So you might have a bunch of risk factors, but the patient doesn't have any, at least at the moment, atherosclerotic risk or established atherosclerosis, then your lipid treatment management will be completely different. So I think there is a tremendous amount of value to that, the score risk. For my work, I also deal with advanced kidney disease patients. It's my subspecialty of treating patients with chronic kidney disease with minimal contrast or even no contrast angiography. And it's very hard to risk assess those patients. So if the patient's eGFR is less than 30, all these cardiac risk factors calculators go out of the window because they are not calibrated. They don't have discriminatory value. And as you know, there's a lot of fibrocalcific plaques in those patients. So unless if the patient got CKD, eGFR more less than 30, the cardiovascular risk factors are very, very worse. And nowadays combined with calcium score. Okay, any other questions?
دوستان اگر سوالی دارن مطرح بفرمایند. ضمن اینکه اگر کسی میخواد سوالش رو به صورت شفاهی هم مطرح کنه میتونه که دستشو بالا بگیره تا من میکروفونش رو آزاد بکنم.
بله. خشایار میگه که you mentioned a couple of times ezetimibe instead of statin. نه، من به جای استاتین نگفتم به هیچ وجه. استاتین اول فرست لاینه. من گفتم تو کسی که فکر کنم یه مریضی که از این کیس ها بود که روی 80 تا از اتروواستاتین بود، ولی LDLش بدین رنج نبود. خب نکست استپ اینه که ازتماب بهش اضافه کنیم. با استپ بعدی واقعا اینه که PCSK9 اینهیبیتور رپاتای اضافه کنیم که اینجا خیلی دسترسی بهش نیست. ولی نه، اینستد نه، استاتین به خاطر اینکه اثرات پلوریپوتنت داره، یعنی ببخشید پلیوتروپیک داره، یعنی فقط کاهش LDL نیست، اکسیدیو استرس رو کم میکنه، اندوتلیال فانکشن رو بهتر میکنه. ازتماب این اثرا رو نداره. بنابراین این جایگزین بعدی برای استاتین هست، کسی که تحمل استاتین رو ندارن و یه ادیشن خوبی هست اون تاپ استاتین، ولی به هیچ وجه به جای استاتین نه.
بسیار خوب. دوستان دیگه اگر سوالی هست بفرمایید، یه فرصت کمی هست. باز سوالی مطرح شد کیوان جان در چت.
Is poor progression of R that extends to V4 considered ischemia? Not really. It really is a single factor, and you need to put that in the context of the patient. You know, what is the pretext probability of having poor R progression, a sign of ischemia? It can be if the patient has got the right profile, if they have symptoms, if they have the risk profile. But per se, strictly speaking, from a EKG point of view, has got some specificity for ischemia, but is not very high, to be honest, compared to other forms of, ischemic ECGs. But if this was in an obese diabetic patient who gets short of breath, walking a few steps and the chest pain, I would have high index of suspicion that this is can be ischemic. Whereas in a patient with not many risk factors or asymptomatic, it could be due to lead placement, etc. PCSK9 is available now PBS for non-family symptoms LDL above 2.8. It's great. Good to know that. I kind of know that through the lipid clinic that we have for young people in RPA that we can get access, but that's great that they expanded the actual indication for it. But with high risk estimate for cardiologists. Yeah, absolutely. I mean, we love to see patients, obviously. That was question was, is it appropriate to send a patient without having any symptoms, but with high cardiovascular disease risk, assessment to cardiologists, or only optimal medical therapy? Look, I mean, you guys can do a good job of assessing the patient's risk. As I said, have low threshold to perform calcium scoring. I think it's a very good tool, and also a cost-effective tool to intensify, to look at the intensity of your medical therapy. Symptoms per se, they don't dictate that, you know, how what your screening. They don't dictate your screening. I think calcium score in patient multiple cause risk factor is reasonable. We are obviously happy to see patients if you want to ask to add more inputs, but I think you guys are more than capable to assess the risk, treat the risk, and have more additional testing, including calcium score, to intensify your therapy. But we're more than happy to be involved in that process as well. Afshin is asking about PCSK9. It increases incidental pulmonary nodules. Yes, I'm aware of that, but I think in patients with really high risk profile, I think one of the patients that showed had really high risk profile, previous MI, earlier course of within the range of 3.6 on 80 of Lipitor. Ezetimibe at its best is going to reduce that level by 0.5, 0.6. So you're going to be stuck at around 3. You can push this patient down to 1.5, 1.4, and there is a clear reduction in events with PCSK9 in such a high-risk patient who's on maximum therapy. So I would consider that for those type of really high-risk patients. Okay, any other?
بسیار خوب. اگر که سوالی نیست، یک سوال دیگه هم هست اینجا که اونجا اگر ببینید.
I believe so, yeah. CTCA should be ordered by a cardiologist, correct? Otherwise not covered. I believe that's true, correct? In terms of rebating.
بله فکر میکنم که ریبیت نداشته باشه.
درسته. برای اینکه خود بر اساس نتایج اسکیمیا میدونن که یوتیلیتی CTCA بیشتر خواهد شد. بنابراین فکر میکنم یه جورایی میخوان کنترل کنن که چه مقدار CTCA انجام میشه اتسترا.
یک سوال دیگه هم مطرح شد که اونجا فکر میکنم آخرین سوالی باشه که جواب بدیم.
Does Lescol work? Can you tell me the generic name of Lescol? Reza answered that question. Yes. Okay.
نه فکر میکنم رضا جان اون بحث چیز رو فرمودن در رابطه ریبیت بودنش یا نبودنش.
ریبیت بودن رو گفتم. بله. من لسکول رو میدونید چیزش چیه؟ جنریک نیمش؟ من نمیشناسم لسکول.
آره.
کسی که الی ممکنه خب به ما بگه لسکول چی هست؟
فلووستاتین هست دکتر جان.
فلووستاتین. ببینید من خودم به شخص پراوکول استفاده میکنم بیشتر پراوستاتین و تا حدی کنترل بهتر، یعنی تا حدی بهتر چیز میشه، افکتیو نیست به اندازه بقیه استاتین ها. من با فلووستاتین خیلی تجربه ندارم. من نمیدونم بقیه تجربه دارن شما یا بقیه کسایی که هستن توی گروه. من به شخص خیلی تجربه با فلووستاتین ندارم.
بسیار عالی. با این به قول معروف میرسیم ما به انتهای برنامه و من میخوام خیلی تشکر کنم ازتون کیوان عزیز. بحث خیلی خیلی روشنگری بود از این بابت که آیا چه جایی هست برای راش کردن و برای اعمال اینویزیو یا نان اینویزیو و تاکید شما روی اپتیمال مدیکال تراپی و نگاه کردن به سیمتوم و بررسی فایده در واقع اینویزیو یا نان اینویزیو در دراز مدت و در کوتاه مدت. فکر میکنم یک معیارهایی به دوستان و به خود من البته داده که بهتر بتونیم با مریض صحبت کنیم و به یه نتیجه قطعی و شیر دیسیژن میکینگ برسیم. به هر حال
بله حتما این شیر دیسیژن میکینگ خیلی مهمه. اولا که امیدوارم که به هر حال دیتا به اندازه کافی منتقل شده باشه و اینکه واقعا دیتا توی ریل لایف به همین آسونی نیست. خیلی باید فیتش کنیم به مریضی که داریم میبینید. ولی خب optimal medical therapy very important. و بعد setting the goals with the patient, you know, what are you trying to achieve really by invasive approach is very important, and I hope that you take that away. این مسیجی که از این در میاد بالاخره.
خیلی خیلی متشکرم از شما. باز ممنونم. دوستانم پیام‌های تشکرشون دارم می‌نویسن در اون چت، اگر ببینید. برام خیلی ممنونم از شما مجدداً و همچنین از دوستان عزیزی که شرکت کردن و دوست عزیزم دکتر شکرچی و دکتر بابازاده که توی برگزاری این جلسه ما رو همراهی کردن و کمک کردن. خیلی خیلی ممنون. شبتون خوش.
متشکرم. شب همه بخیر.
قربون شما. خدا حافظ.
مرسی.
خدا حافظ.
خدا حافظ.